Today,
Good afternoon. Sunil, can you see the slides?
yeah, we can see.
Okay. Brilliant. Okay, thanks.
So, good afternoon. Today, our session is on interventional pain management in head and neck pains. And as usual, our faculty is Dr. Vijayanand. He has been very kind to us for many sessions on interventional pain management. And this will be his last session on interventional pain management. And I request Dr. Vijay to please take over the session.
Thanks, Sunil. Very good afternoon, everyone. See, my internet connection is a little bit patchy this afternoon, so I've switched off the video so you can just hear my voice. I'm just hoping that the voice kind of goes on well till we finish this little presentation. Now, I mean, with regards to headache and facial pain, at least 20% of the pains which the neurologists see or the dentists see or the neurosurgeons see, they're all kind of refractory to the usual medical treatment. You know, the migraines, they start someone on triptans, ergotamines, and whatnot, the anti-inflammatories. As abortions, it still doesn't help. And if you look at prophylactics like beta blockers or calcium channel blockers, anticonvulsants, particularly for migraine, it doesn't seem to help. So there's a lot of things we can do from an interventional pain perspective, which might be of use to these people suffering from headaches and facial pains, and not just migraines and the usual facial pains, but I think you can possibly pick up a few things which might be of use in your own practice in head and neck cancers as well. Not all procedures, but some of them might be useful. So if you note down any of the procedures, we can have a longish kind of talk at the end of it. Okay, so what we're going to do is, you can see that, the type of headaches there. And we're going to sort of pretty much look at most of them this afternoon and what could possibly be done. You can see the common one is the migraine. You have the tension type headaches, the cluster headaches, the CDH, the hemicrania, which is a little bit rare. Cervicogenic headache, which we will see a lot of them this afternoon. There's a post-dural puncture, occipital neuralgia, trigeminal. We'll kind of talk about all these things, not about the conditions, but what we can do from an interventional pain perspective for these procedures. The challenge is, if you look at the new ICHD classification, which is the International Classification of Headache Disorders, there are nearly 300 different types of headaches. And I suspect even the neurologists would kind of remember all these kind of headaches to treat the patient. So this is the biggest challenge. For instance, if you look at the migraine alone, you could see that, you know, there is migraine without aura and with aura, under which there are 6 categories, and then there are childhood problems, which there are 3. There is the retinal migraine, and then there are complicated migraines, and then probable migraine, which means there are a lot of conditions which we do not understand very well. But what we're going to do this afternoon is not talk about the conditions, but because my remit is to talk about the interventions, you know, what could possibly be done for these conditions. So I'll have some sort of a system in order. I mean, headaches are not that simple, but I try to simplify it, mainly because for my own understanding. So we're going to talk about the peripheral nerve blocks to start with, the different sort of peripheral nerves. We look at it, including the auriculotemporal, the greater auricular, the maxillary, the mandible, the infraorbital, the supraorbital, the supratrochlear, all those nerves. And then we're going to look at the occipital nerve blocks, which is quite useful and comes in very handy. Then we're going to look at glossopharyngeal nerve blocks. We're going to look at ganglion blocks after that, which includes the trigeminal ganglion and the sphenopalatine ganglion injections, which might come in handy in certain conditions, particularly in cancer pain. It might be of some use. And then we're going to look at the cervicogenic headaches, and which is something which is neglected or very rarely kind of diagnosed, and how problems in the neck can present as head and facial pain. So that we're going to look at. And some sort of a brief, very, very brief sort of overview on the surgical sort of options available, like the deep brain stimulator and a motor stimulator for the pains. Okay, so briefly, this is what the main sort of nerve supply to the head and neck sort of looks like. You have the trigeminal nerve, we have the ophthalmic, the maxillary, and the mandibular division of the trigeminal nerve. which kind of divides into supratrochlear, supraorbital, and this is the kind of common nerves which we block from a peripheral nerve perspective. We look at it in a little bit more detail. If you look at your image on the left, so you can see the three branches of trigeminal, which is supplying the front or the ventrum or ventral of the face. The behind the blue shade is what is supplied by, or what is kind of carried by the great occipital nerve, the lesser occipital nerve, the auricular temporal nerve, things like that. So the right kind of gives you a little more information. If you look at the first branch, you can see SO stands for supraorbital. There is supratrochlear, there is infratrochlear, there is external nasal, which is EN. And if you look at the second branch, you have the infraorbital, you have the ZF, which is the zygomaticofacial, the ZT, which is the zygomaticotemporal. And if you look at the third branch on the right side, the AT is the auriculotemporal, the B is the buccal, the M is the mental. So these are the little divisions, the three main divisions of the trigeminal nerves. So it is possible to block these nerves individually. And I'm not going to go into each and every nerve and how we're going to block it, but I have to pick out the most common ones which we do in our practice. And most of these head and neck procedures we do in our own practice. And we look at the posterior part of the head, so the GO stands for the greater occipital nerve, the LO stands for lesser occipital nerve, the GA stands for the greater auricular nerve, and the AC stands for the ascending cervical nerve. So, so this is the sort of distribution of what we look at. So first what we'll do is we'll look at the front of the face, the forehead. So the top picture on your left, it shows the supratrochlear nerve and the supraorbital nerve. The trochlear nerve is the one which is medial, and the supraorbital is the one which is slightly lateral. And that's the injection is a schematic sort of representation. Right. Guidance. So you could see the image at the lower half of the screen. On the left side, you could that's the ultrasound image where we kind of trying to visualize the supraorbital notch by tracing the supraorbital ridge, and you could see the image on the bottom right where the ultrasound probe is kept. So we identify and we inject close to the nerve. Now, the most important thing to remember, particularly when it comes to peripheral nerve blocks in the head and face, is we don't have sort of great quality studies to back it up. In that, we don't have any sort of double-blind randomized trials. And the other thing also to remember is the face is highly vascular, and we have to be very mindful of how much local anesthetic we put into these peripheral nerve blocks. So, 100 milligrams of lidocaine could prove quite toxic if it is injected in the facial area. And also, there is for the same reason, there is a higher sort of post-procedure, ecchymosis and hematoma sort of things, which is quite common. And when you kind of injecting the supraorbital nerve or the infraorbital nerve where you're close to the foramen, it is very tempting to place the tip of the needle as close or into the foramen itself to block the nerve. But that invariably ends up in nerve damage. So we have to keep well away from the foramen. The same with the mental nerve as well. So these are the common sort of basic rules while doing peripheral nerve blocks. And this we are looking at the infraorbital nerve. This is typically supplies the cheek, the cheek as well as the latter part of the nose. And here we kind of trace the zygomatic bone to find out the infraorbital foramen, and then you can see that the infraorbital nerve is situated in there. And here too, we have to be very mindful of not getting too close to the foramen because it can easily damage the infraorbital nerve. So these two are the peripheral nerves. I think I have a few more of the peripheral nerves to show you this afternoon. Now here, this is the auriculotemporal nerve, which can be blocked. I mean, we typically do it for atypical facial pains, even in temporomandibular dysfunction. We kind of block the auriculotemporal nerve, and the Ramsay-Hunt syndrome, the geniculate ganglion herpes infection. Now, I have to say that I haven't seen a Ramsay-Hunt syndrome in my practice so far, but it is something which you could try. So it's a very, very simple, it's a superficial nerve block. Here again, you kind of locate the zygomatic process with your probe, and then look at the temporal vessels, and the auriculotemporal nerve is in very close sort of proximity to the temporal vessels. And it's a very, very superficial injection. You just need to go 0.5 centimeter and you're close to the auriculotemporal nerve. So it's a very useful sort of nerve block to have in your armamentarium, particularly if you're looking at pain around the mandibular notch. Okay, and this is the greater auricular nerve. Now, with the auricular temporal nerve, we have to be sort of careful with the not to damage the temporal artery. So that's an important point to remember. Now, the greater auricular nerve, again, it's quite easier to kind of trace it, but again, it's quite highly vascular. It's basically superficial to the sternomastoid muscle. You can easily trace it at just half a centimeter from the skin, and it's possible that you can block it. So these are the common ones which we do. I mean, I'm sure quite a few, but the commonest ones of these would be the supraorbital and the supratrochlear, which we do it together. The infraorbital sometimes we do, and the auricular temporal. These are the common ones what we do. Now, apart from that, this again is a very, very common procedure in our pain clinic, which is the greater and the lesser occipital nerve blocks. Now, this is just a schematic diagram. You could see the occipital artery at the top. And to the medial of the artery is the greater occipital nerve, and lateral to the artery is the lesser occipital nerve. And you could see the sort of muscle attachment. You have the trapezius, the sternomastoid. At the top, you have the semispinalis capitis, and just underneath the semispinalis is the splenius capitis muscle. I mean, this is a very, very common procedure. What we do, the occipital nerve blocks, and this is how it is. I mean, it is just a line diagram, but what we normally do is to actually trace look at the occipital protuberance, place the probe there, and then trace the nuchal line laterally, and then identify the occipital artery, and then just medial to the artery, you can find the greater occipital nerve, and then you can trace lateral to the artery along the nuchal line, and you can get hold of the lesser occipital nerve. Now, these pains, they typically present as significant sort of headaches, where they also sometimes they do get paresthesias, and with a bit of luck you can elicit what's called the Tinel sign. So you can tap the nerve on the nuchal line and you can reproduce the paresthesias of the scalp. So this is something which is very, very easily missed by the neurologist, and which is something which could be very, very easily treated. In fact, we did one just a couple of hours before this talk. We did one lesser occipital nerve block for a lady who's been from one neurologist to the other, trying to find a solution for her headache. Now, this is something which we do not do very often, but when it presents, its presence is a bit of a challenge because there is a lot of diagnostic issues with that, which is the glossopharyngeal nerve block. They also call it the Eagles syndrome. So if you look at the top left of your screen, I mean, you look at the top right of your screen, you can see the line marking the styloid process, and the glossopharyngeal nerve is in relation to the styloid process. It's just behind the styloid process and posterior to the styloid process. They say in Eagles syndrome that there's an elongated styloid process which digs into the glossopharyngeal nerve, and it typically presents as a sharp sort of paroxysmal pains just behind the angle of your jaw, in the tonsillar area, in the base of the tongue, and sometimes you even get those sharp pains in the ear, particularly with swallowing and speaking. It's something, it presents very, very similar to trigeminal neuralgia. Sometimes you get sort of thrown off the diagnosis because of the typical presentation. And the only way you can confirm that this patient has a glossopharyngeal neuralgia is to actually block the glossopharyngeal nerve to see if the pain is relieved. So this is what we typically do. So at the lower half of the screen, you could see the needle, which is kept in very close proximity to the to the styloid process. You just hit the bone and then you walk off posteriorly and inject some contrast, because there are a lot of vessels which is in very close proximity, including carotids and internal jugular veins, and there are a lot of other nerves apart from the glossopharyngeal nerves. So you've got to be very, very careful. Though it looks very comfortable and easy on screen, it is not that easy actually, because typically the first problem you face when you put a lateral view of the skull is to identify the styloid process, which kind of keeps wandering off depending on whether the patient moves the head by a few millimeters this way or that way. But it's a very rewarding procedure. We put in some local anesthesia, the pain relieves, and then you can plan some pulse radiofrequency ablation of that glossopharyngeal nerve. And this kind of a line diagram shows how tricky it could be. The styloid process, and just behind is the internal carotid artery, just posterior to that is the interjugular vein, and you can see a bunch of nerves which is in very, very close proximity. Okay, so we need to block the glossopharyngeal, but you also have the accessory, the hypoglossal, the vagus nerve. So it's very, very sort of important when you do that. And an important point when we do the glossopharyngeal nerve injection is monitoring the cardiovascular parameters, because the carotid sinus nerve is actually a branch of the glossopharyngeal. So if you're going to block the glossopharyngeal, the patient might go into bradycardia. So we need to sort of definitely monitor the cardiovascular parameters. So that's the glossopharyngeal nerve block for facial pains. And then we kind of move on to the sphenopalatine ganglion. Now, I think I just put this up so that, I don't know, I'll send the slides to Sunil, who could possibly share it with all the participants. But I just put the slide up just to show you how complex the neck pains and the head and facial pains could be, because there is a lot of communication between the trigeminal vascular system and the sphenopalatine system. The sphenopalatine ganglion is the largest parasympathetic ganglion extracranial, and it is situated. You can see this. This is what we do quite a lot of these sphenopalatine ganglion blocks as well as ablations. If you look at the screen, you could see the needle as a target and like a dot point. And around the needle, you could trace it like a flower vase. We call it the inverted flower vase appearance. So you go at the top of the flower vase and looking at it. So that's, you can see the newer image. On the left side is where the needle tip is. It's like an inverted flower vase, and you go at the flower vase. And then you also have to look at it with the AP view, and you could see that the needle is in very close proximity to the wall of the nose, actually, and that's where it should be. And you could also see that just about that is. So one complication which we're always worried about when we try to do the sphenopalatine ganglion is going through the orbital bone into the globe of the eye. And what we can do is we put in some local anesthesia to see if they can reduce the pain, and then it can relieve. This can be used for conditions like cluster headache, atypical facial pains, migraines, and sometimes even cancer-related pains too on one side face. And with the radio frequency, what we do is we insert the needle, same principles, we get to the nose, and then we do some stimulation, and the sensory stimulation should typically be felt at the root of the nose. So if you feel it in the upper teeth, in the gums, or if you feel it in the hard palate, then it makes sense to just move the needle around a little bit so that we can catch the efferents of the sphenopalatine ganglion, and it's quite rewarding in many ways. So so that's the sphenopalatine, and what we then do is we're going to look at the trigeminal ganglia and the trigeminal ablations. We do a lot of them. We do at least one or two of them every week, the Gazerian ganglion block and the ablation. We don't do the blocks, we just go for the ablation straight away. And these are the paroxysmal pains. It could affect the first, second, or the third division, typically brought on by chewing or any other triggers like brushing the teeth or washing their face. You can see on the image on the left side, where the tip of the needle is the foramen ovale. Now, how we get this foramen ovale, when you do it, it's a little bit tricky actually, because everything looks like a foramen ovale. So you got to be sort of 100% sure that you're in the right foramen, because we could do a lot of damage going into the rotundum, the coronary foramen, and all sorts of things. So this is it. So this is basically, it's a submental view with the ipsilateral oblique looking into the foramen ovale. And normally we just sight the needle, go in straight in, and to the right side of the image is when we look at it from a lateral perspective. You can see the tip of the needle is just behind the sella turcica on the right side, and it is in relation to the petrous bone and the clivus bone. And at this stage, sometimes CSF tap, we're not sure that we are in the Meckel's cave and closer to the ganglion as possible, and then we do the sensory stimulation, and we normally, so we can easily you want to lesion. So if you want to lesion the V3, we kind of try and stimulate and get closer to the V3, and the stimulation should be at less than half hertz, and based on that, gives some 3 to 5 years of benefit. We do quite a lot. Last year we did nearly 150 of these procedures, so we still continue to do it with percent success rates procedures. So that's the trigeminal. And this, again, if you want to do a maxillary nerve block, approach it through the trigeminal, or you could approach it through the spinopalatal. You could see it's the inverted sort of flower vase appearance, but the tip of the needle is right at the roof of the flower vase, where there is a foramen rotundum beyond which the maxillary nerve runs. So you can do it this way as well, but we very rarely use this approach to target the maxillary nerve. Now, moving on, I think this is a very important thing, which is something quite easily missed as well. Neck, pictures in the neck as a source of pain in the head and the face. You could see those images. If you have C2-3 facet joint, you could have headache. If you have C3-4, you can have sort of head and jaw pain. And similar, so the different facet joints, they can present with pain in different parts of the head and the neck. And typically what we do is we kind of do some very specific provocative tests and to try and pick up which possible, say, head nodding and extension of the neck, lateral flexion of the neck, palpation, and all those things to pick up the possible source of pain. Now, out of these, the atlanto-axial joint, the C2-3 facet joint, and pain, but the atlanto-axial could be a source of pain. So we're going to briefly look at the interventions, what we do. To bear in mind when doing the neck injections, because the vertebral artery is kind of very, very close to these medial branches in the dorsal primary rami. As you go up in the top, at least it's hidden the vertebral foramen up to C2, but above C2 it is kind of open, it is exposed, so you can easily sort of puncture the vertebral artery, which might result in infarction, cerebral infarction. So you've got to be extremely careful when dealing with neck procedures. So you can see the needle, it's in the C1-2 facet joint. You can see the odontoid process. I mean, it's difficult for me to explain. If I can, yeah. See the arrow in my screen? In your screen, can you see the arrow?
Yes, yes.
So that's the atlanto joint. Yeah, and so you have two images here. The one to the right is the third occipital nerve block. So here you have the C2, C3, and you have three needles placed. And basically do the stimulation, you heat it up to 70 degrees, and that kind of gives a decent. It's from an AP perspective, sitting at in relation to the lamina, you can see the joints here, and this is the tip of the needle, and this is where the medial branch is hooked to supply the facet joints. And here again, the sensory stimulation, and if stimulation, then we go and ablate the nerve. Okay, and this is the same sort of medial branch blocks of the neck, but looking at it from an AP perspective. On the left side, you could see we call it the scallops. This kind of wavy sort of things, and this is the waist around which the medial branch is hooked to supply the joint. It kind of hooks to supply it. So go in there, and this is what it looks like on the lateral view, the tip of the needle. And you can put some local anesthesia, good benefit, then you can go and burn the nerve with conventional RF. Normally it works for 3 to 5 years, with a bit of luck, longer. So it's one of the common causes of neck pain, which also goes up the head. And this is just a needle of the radiofrequency. This is what we do, place the series of needles, stimulate them, and then put some local anesthetic and burn it. So these are the common sort of injections, what we do in our own clinic. Now, these are something which we don't do that many, but we do have some experience. This is the Botox injections for the different sort of migraines and the chronic tension headaches and whatnot. And where you want to inject. Now, the Botox A is what we use on a botulinum toxin A is what we use. And these are the points where you want to inject the Botox. So if it's a frontal headache, you're looking at what's called the corrugator, which is just above your eyebrows, the procerus, which is exactly in the middle, and the corrugator, which is at the top. The frontal is the procerus, and the corrugator. If you have a temporal sort of a headache, you inject into the temporalis. There are 4 points on either side, so you put some 40 units in total. Similarly, for the occipital headache, you have some 6 points injecting into the occipitalis, and about 30 units is what we inject, Botox injections. And for posterior sort of headaches, you have the cervical paraspinal muscles as well as the trapezius. We can inject something like 30, 50 units to reduce the headaches. Typically, it's the neurologists who are quite comfortable doing these Botox injections for migraines. And I'm not really sure in terms of the long-term benefits and how long they work, but normally they say it works to keep Botox injections for the migraine. Okay, and this is a much more advanced, and I haven't done this procedure in India, but I have done it when I was training. There are multiple indications, mainly for migraine. They do it. It's called the occipital nerve stimulation, where you make a small nick in the near the occipital, near the protuberance, and then this is what we call the surgical leads or the paddle leads. You could see those electrodes are flat; they are inserted underneath the scalp. But what we do as this opaque cylindrical percutaneous leads, these are tiny sort of leads which go just underneath, and you can place it across both the greater occipital as well as the lesser occipital nerve. And there is a IPG or the battery which is kind of implanted as well, which gives them continuous currents, which relieves the pain to an extent. So it seems to be picked up very well in Western countries, developed countries, where they do a lot of these occipital nerve stimulation for migraines. I don't think we do that many in India. I mean, patients who they have tried, but I don't have any experience of dealing with patients in India. And this is the sphenopalatine ganglion. I mean, we talked about the sphenopalatine ganglion block. We've talked about the ablation. But in cluster headaches, this is something which the neurosurgeons do. This is a very specific surgical procedure where they use a surgical introducer, get to the sphenopalatine ganglion, and then implant a stimulator close to this sphenopalatine ganglion, and it continuously stimulates, and it seems to work very well in cluster headaches. There's a lot of studies there, but again, none of them are kind of randomized or anything like that. It's just a long case series, 10 patients had the sphenopalatine ganglion stimulation, and they're all doing excellently well. So I'm not sure how you will interpret it in terms of evidence, but that seems to be one option to treat your atypical headaches and cluster headaches. And these are typical sort of neurosurgical interventions for head and neck. That's the deep brain stimulator with a pulse generator implanted, where the tip of the needle is quite sort of deep, close to the past the BPL and the BPM. And this is what we call the motor cortex stimulator, where the paddle leads are kept on the cortex, and they do the stimulation. And one other thing which I haven't mentioned is something called the intraventricular opioids, particularly in head and neck cancer patients. This is something which the neurosurgeons, seen the neurosurgeons do, where they insert a catheter and put it inside the ventricle. There's a tank outside. You can fill the pump and you can just press so that it delivers something like 0.5 milligram morphine into the ventricular space, and it seems to produce some excellent pain relief. But I'm not sure whether the neurosurgeons in India would be comfortable doing it, because it's basically stereotactic neurosurgery. So you kind of insert the catheter and insert it into the ventricle itself under sort of in stereotactic sort of table and condition. So that's something else to think about. I have seen one. I've never done one. I've never seen one done in India. That's the intraventricular opioid. So I think that covers the whole range of interventions which you could possibly do for head and facial pains. Now the thing is, I have talked about the head and neck interventions from a pain physician perspective. Some of them might be quite useful for you from a cancer perspective. So particularly the trigeminals, we do a fair amount of trigeminal ablations for cancer pain. The facial pains, we do a number of pain ablations as well for cancer pain. So I think just a quick thing through the algorithms. So if you do have someone with migraine, you look for potential causes for chronicity. If it's medical overuse headache, then there's a different sort of algorithm. But there is no medical overuse. You think about Botox, no response. You think about IV infusions like valproic acid and whatnot, no response. Then if it is occipital pain, then you look at occipital nerve block and stimulation. If it is autonomic features, the migraine, just particularly conjunctival injection you get a lot of secretions, nasal stuffiness, and things like that. You do the spinopalpine block and the spinopalpine stimulation. So this is the kind of algorithm which can be used to treat chronic migraine. So it doesn't just stop with the triptans, the beta blockers, the calcium channel blockers. There are a lot of other things you could do for migraine. So that's something to bear in mind, actually, because the neurosurgeons have just moved on from treating them purely with medications to Botox, whereas from a pain perspective, we have the occipital nerve stimulation and the spinopalpine ganglion blocks and stimulation for migraine. Now, if you look at medication overuse headache, now you have to sort of make sure that these are not the optimal doses of prophylactic medications. The prophylactic meds include the antidepressants, anticonvulsants, the beta blockers, calcium channel blockers, and we know the abortive medications. The abortive medications are the typical ones which you stop. The patient gets medication overuse. The abortive medications are anti-inflammatories, the triptans, the ergotamines, the opioids, if they are on opioids. So these are the drugs which have to be weaned off very, very slowly. And you can think in terms of IV infusions or occipital nerve headaches. Now, occipital headache, you look at treating it conservatively, and you also, the main thing is to rule out red flags. You look for posterior fossa tumor, any vertebral artery aneurysm, and if there isn't, then you look for whether it's a myofascial pain. There are any trigger points in the occipital muscles. You just do the trigger point injection. If the pain is made both with cervical movements, you think it's cervicogenic headache, which has got a separate algorithm, which I'll show next. And if it's neuropathic pain, which has got paresthesia over the scalp, and you think it's occipital neuralgia, you can do an occipital nerve block or occipital nerve stimulation. Now that's the cervicogenic headache. So pain in the upper cervical spine, movements, and that kind of goes up to the head. The first thing which you have to rule out, which is the common one, is it's a myofascial, because the trapezius, the splenius capitis, the semispinalis capitis, the sternomastoid, everything gets attached to the skull, so it could be is the commonest one. So if you could rule them out, then you look whether the patient gets worse pain with nodding the head, in which case it's atlanto-occipital headache. We normally do not inject the atlanto-occipital joint because it's a very risky joint to go anywhere close to the needle, because the vertebral artery is just exposed naked, and just a millimeter here or there, you can easily damage the vertebral artery. If we have pain with the rotation of the head, then it's the atlantoaxial, which is very commonly done. And if the patient do get a good response to the local anesthesia injections, we go into radio frequency ablation. And if it is a whiplash injury, you're looking at third occipital nerve blocks and third occipital nerve ablation. So we have some sort of an algorithm for cervicogenic headache. Neuralgia, it's very sort of straightforward. You get an MRI scan, find an aberrant vessel, not find an aberrant vessel. In a young person, you would recommend them microvascular decompression, because there's a better chance of success and probably a longer duration of effect with the microvascular decompression. If it is an elderly patient where there is evidence with or without vascular compression, we do the radiofrequency thermocoagulation, and it is not that expensive, even in private practice, compared to gamma knife. They have 90% plus success rate, and it usually lasts for 3 to 5 years. So that's what we do in our clinic. So I'll stop there. So very much for listening. And I think I've covered most of the interventions, what we do, and from a head and neck perspective. So I think I'll leave it to Dr. Sunil to continue. Thank you.
Thank you, Dr. Vijay. So I think it was an extensive overview about interventions on head and neck pain. The session is open for discussion.
Sir,
Yes,
Dr. Thank you so much for wonderful. Thank you so much for a wonderful presentation to Dr. Vijayanand. Just wanted to know when is the time we should consider for interventional pain management in head and neck cancer?
Okay, for all the people who joined late, the reason why I am not visible is my internet connection is very poor. So Sunil has advised me to switch off the video so that at least we can hear. So that's the reason why I'm not visible. Now, the interventions that are, I mean, normally it is the conservative management. Say, for instance, if it's if there's oxygen neuralgia or trigeminal or atypical headaches, they started with the conservative management. First, you roll out red flag conditions, then you do the conservative management using pain medications. And if it doesn't, then that's when we start doing the interventions. Because most of the head and neck interventions, they're not just simple blocks, because we end up ablating them at some point. And if you're going to heat up the nerve, or if you're going to neuromodulate the nerve, then you've got to be absolutely sure that we have done all possible conservative measures before we jump in. I know there are certain sort of interventions where people would argue, you know, rather than putting them on medications and kind of filling them up to their eyeballs with medicines, you might as well do a simple intervention which would give them the benefit. But most of the head and neck interventions are sort of irreversible if you think about it, because they're all sort of ablations and neurostimulation. So I think this is probably one area where you would like to give it all your conservative measures a go before we jump in and do the interventions.
So, Dr. Vijay, in case of carcinoma pancreas, sometime even before conservative management, we go for celiac or longitudinal block. It is not like.
I can understand. This is the reason why I was mentioning. Because celiac pancreas, there is some evidence to suggest that if you do a celiac neurolysis before you start them on opioids, then the lesser sort of opioids you use, which means lesser sort of immunosuppression, and people generally do better. But I don't think there are any sort of studies to suggest that doing a head and neck intervention early might be useful. But the one thing we also have to keep in mind, particularly in cancer situations, because the anatomy is distorted all the time. So if at all you want to do the interventions, is before the anatomy is completely distorted, because it then becomes difficult. You can't do any intervention ultrasound guided. It has to be, most of the interventions will be with the fluoroscopy guidance only, because of the distorted anatomy. So that's one thing which might sort of push you into doing an early intervention. But otherwise, I mean, I would rather sit and wait, treat it conservatively before I jump in and do the procedures.
Hello.
Yeah.
I have two questions.
Yes, please ask.
Yeah. Firstly, what is used whenever we do the peripheral nerve blocks that were mentioned, the ultrasound guided ones? What is used to block it? Do you do a pulse radio frequency? And my second question is that in non-cancer pain, when do we go for, how long do we try conventional before we consider interventions?
Okay, the first question, I mean, it was kind of breaking up a little bit. Can you clarify once again? I just caught the pulse radio frequency bit in the end, actually. I didn't get the intervention which you mentioned. If you could mention it once again, please. Yeah.
The peripheral nerve blocks, like the greater auricular or the greater and lesser occipital nerve blocks, what do you use to block it? Is it blocked pharmacologically, or do you do a pulsed RF? That was my first question.
Okay. I'll answer the first question and then we'll go on to the second one. So what we do is it's all done under ultrasound guidance. I mean, we don't do any peripheral nerve blocks under fluoroscopy. You can pick up these nerves quite easily with the ultrasound. What we normally do is just put in some 1% lidocaine, just a few drops of it. And if they have a good benefit, then it depends on the condition, actually. Most of the times we end up doing pulse radio frequency only. The reason is because these nerves are so superficial. Even a radio frequency needle with half a centimeter tip, it will easily burn the skin, actually, because it's just underneath the skin and you end up with a big hole in the skin. So we tend to do under pulse stuff. That's one of the practical problems. Where if you're doing a supraorbital, it's just a couple of millimeters down the skin and you're on the supraorbital already. And if you're going to burn it with a 10 millimeter tip, you end up making a big hole in the skin, actually. So we do a pulse radio frequency, fully aware that the pulse RF is not fantastic compared to conventional RF, but we still have to admit it. And sometimes we do put phenol, a few drops of phenol, particularly in cancer situations where we don't have much to lose. We are opting for these kind of expensive options. We just go and put a drop of phenol, and that seems to do the trick. Now, your second question, you are asking something on lung cancer pain. Is that right?
My question was, in non-cancer headaches, how long should we try conservative management before we go ahead for intervention?
Okay, so in non-cancer pain, see, the thing is, I mean, it's a tough one. You would still want to try all the conventional sort of treatment because most of the head and neck pains. Okay, so if you're looking at a nerve irritation pain, you want to look at something like trigeminal neuralgia, for instance. People would like to try the medications, the oxcarbazepine, carbamazepine, and if it doesn't work, or if you don't like the side effects, or the dose just keeps going up, that's when we start thinking about the interventions. That's the trigeminal neuralgias, the spinal ablations. Whereas if you look at the cervicogenic headaches, which is our kind of bread and butter, where we do a lot of ablations in the neck and the occipital nerves. Now the thing is, the commonest cause for these pains is myofascial. 80% of the times it's myofascial pain. And we would like to give a good go with a rehabilitation physiotherapy approach where we can do some deep tissue massage and some exercise and whatnot. And if they do not respond, then we offer them the interventions, because the only other option you have for cervicogenic headaches is anti-inflammatories, and it is not something you can go on and on just with the medications, because we'll be creating a lot of business for the nephrologists, which we don't like. So we go into the conventional radiofrequency ablations. Typically, we do the lidocaine injections, good response, then we go into the ablations.
Yes, madam. Madam, 1 minute. Madam.
Oh, sorry.
Yes, please.
No, I just want to compliment Vijay on this excellent presentation, in which in such a short time he's managed to cover so much. I just had a question regarding glossopharyngeal neuralgia. You were talking about the approach from outside, but what about the intraoral approach? Would that be safer than this, like injecting at the posterior tonsillar pillar? Would that be, I mean, because you said that areas, you have all the carotid and the internal jugular and all that. So considering all those vital structures, would this be a little safer procedure for glossopharyngeal neuralgia?
Well, good question, madam. I mean, honestly, I don't know the answer whether it'll be a safe, but I think I mean, if you're going to approach it from the intraorally, again, the structures which are surrounding the glossopharyngeal will be something very similar, actually. I mean, it's typically, I don't know, probably the ENT people are quite comfortable doing it. Just behind the tonsillar pillars is where you go and inject for the glossopharyngeal, and probably safer. I don't know. I don't honestly know that, madam, but I mean, I'll look it up. I think intraoral is what people have always done from an ENT perspective, and I think they use it to block for the awake intubations as well. Madam would sort of know it better than me, because I don't practice anesthesia much.
The other question, just one more question. We have a lot of patients with CA tongue, and they've already had the surgery, reconstructive surgery. They would have already received radiotherapy. So there's they later on complain of a lot of pain. Mouth opening is restricted, and they have a pain in their mandibular area. What can we do in such a situation? Because like you said, all the anatomy is distorted. Giving a nerve block also may not be the best thing to do. So can this only be treated conservatively, or do you have any better options?
No, madam. For the tongue, we typically don't have much. If it's pain from the base of the tongue, we could possibly try the spinopalatine. But if it is the anterior 2/3 of the tongue, then it becomes difficult. I mean, lingual nerve is something you could think about. Hypoglossal, I mean, that's more of a motor nerve rather than a sensory nerve. But I mean, our options are very, very limited. As she's rightly said, it's going to be mostly conservative rather than intervention.
Thank you, Vijay. Thanks.
Thanks, madam.
Dr. Vijay, Nandini here. I had a query too regarding an approach for sphenopalatine block through the nose. I have seen, and I've used also a long stick with a sort of a cotton bud at the end of it, which is pushed right through to the uh, end of the nasal foramina. For have you with the local anesthetic block? Have you ever done that?
Yes, yes. Yes. We do it all the time. We do it all the time because we only go and do the ablation after we do this. I mean, what Dr. Nandini Valat was mentioning was is a very simple sort of approach to the sphenopalatine ganglion. Is to get a big. I mean, the normal earbuds won't reach the. It's basically it's trying to reach the middle turbinate of your nose with a cotton wool soaked in lidocaine is what we're trying to do. I think the best option for you would be a long sort of microbiology swab because it's quite sort of a distance from the nostril down to reach the inferior turbinate. So what we do is we soak that cotton wool in lidocaine and then gently introduce into the nostril and keep pushing it till it meets with a solid resistance. Now that's the middle turbinate of the nose, and just in relation to that lies the sphenopalatine ganglion. So we normally leave that cotton wool soaked in lidocaine in that area for a good 5 minutes. And if we can show that the patient responds to that procedure, then we can plan for a longer sort of a procedure like ablation or stimulator. So yeah, that's a very non-invasive approach, and it's done in the office. You just can lie the patient down and put the swab down their nose and see whether it works. But you got to be careful because you're designing your further treatments based on the response to this. We've got to be careful that we are close enough to the middle turbinate of the nose, because sometimes what I have found is, you just put in the normal length earbuds, and it doesn't actually reach the nasal turbinate. So we kind of think that we've inserted deep enough, but it is nowhere near the middle turbinate. And if the patient doesn't respond, it doesn't mean that not blocking the sphenopalatine would sort of is there a cause for this poor response. It's because our procedure itself was wrong. So if you can get hold of a big microbiological swab and you can stick it down the nostril, then I think that's a good one. I think it's a good sort of alternative to start sticking needles straight away.
Yeah, so I mention it here because for us in palliative care, this could be an easy consulting room kind of approach in a head and neck cancer pain patient where we are finding it difficult, and then we could refer to someone like Dr. Vijayanand if this is going to really make the person feel comfortable. Even using this itself, the diagnostic approach itself, I have seen relief of a few weeks. Is that possible, Dr. Vijay? Because I have seen it. I'm surprised because it can never work for more than a few hours. But
I mean, we see that. We've seen it on many occasions. I mean, it's tough to explain why it is. You put in 2% lidocaine thinking it wouldn't work for more than 3 hours, but they seem to go on for the good 3 weeks without pain. But yes, I mean, sometimes we have sent away patients asking them to put some lidocaine spray in a cotton wool and put it up their nose. But yes, that happens. And sometimes if it's going to work for a week, 10 days, it's a very, very easy office procedure. So you can bring them back every week and then you can do it. It just takes, you just need to leave that swab in for about 5-10 minutes, take that thing out, and then they can go home. But I doubt whether they continue to benefit. Maybe for 3-4 occasions they might, but eventually they might end up needing an ablation.
Yeah, that's true. So thanks for clarifying that point. And one more question, just like Mary, that I had was, and another approach is there, isn't it? Way down the nerve pathway of glossopharyngeal around the hyoid, which is percutaneous approach.
For the glossopharyngeal.
Yeah, that's right.
Yeah, glossopharyngeal. I mean, glossopharyngeal, I think it's the styloid actually. We just hit the styloid bone and walk posteriorly. It's the extra sort of oral approach, and the intraoral approach is what Dr. Mary has mentioned. There might be other approaches. I'm not aware actually.
Okay, thanks.
Hello.
Please continue.
Hello. Hello.
Hello. Hello, I have a question, sir. I'm Dr. Manoj from Bangalore.
Please continue, Dr. Manoj.
Yeah, that was a very interesting talk. Although I joined a little late, it was very nicely presented. Actually, the slides on Botox injections caught my attention. All these years, the dermatologists and cosmetologists have been using it like a magic potion, and suddenly it appears like it is something presented to us also to utilize it for various pain management. What is the dosage, if at all it is used for management of pain in our scenario?
Right. Okay. The Botox injections, it's typically done by the neurologist, particularly for migraines. And I think the maximum dose you can ever use is something like 80 units. And I think the vial comes as a 50 unit or 100 unit vial. And on most occasions, it is affordability, which is the problem, because the Botox it costs between 8 to 10,000 rupees for a
Yeah,
vial.
yeah, exactly.
And so sometimes we end up having two patients sharing that sort of amount if you're going to do a targeted interventions. Sometimes for neuralgias, particularly greater occipital, lesser occipital neuralgias, we inject some local anesthesia, they get a good response. You can either stimulate them or you can just put some Botox closer to the nerve, which means the muscles are relaxed. So if you're thinking it's an entrapment where the muscles are trapping the nerve, they do get some good benefit actually. So before we start thinking in terms of ablation or neurostimulation for these nerves, then we just inject a little bit of Botox. But the neurologists, they do quite a lot of these Botox injections these days. And also the people who are involved in, who are in PM, physical medicine rehab people, they do a lot of Botox injections for spasticity and things like that. Migraine, yes, there is a very good emerging body of evidence to suggest that the Botox injections are useful.
Thank you so much. Thank you so much.
I have a question. Sir, do you have any experience with intramuscular stimulation for headaches or for the cervicogenic headaches?
I don't, but I know a lot of people do it. The ultrasound guided intramuscular stimulations, but I don't have any experience. But people have been talking about it for quite some time, actually. I don't. I'm sorry.
Can I ask a question? Hello,
Please go ahead.
I'm Dr. Sushma from Mumbai. I wanted to ask you about like when we get patients with CA mandible with radical neck dissections, they have received a lot of radiation and a lot of scarring there, and they get pain. So, is there any role of stellate ganglion block in these patients if they have neck
Yes,
pain?
stellate. Yes. Yes. If it is CA mandible with facial pains, I think your best bet is to actually do a CT guided trigeminal ablation, actually, because you get easy access to the foraminal valley, and we can do the injection and we can ablate mandibular nerve. But stellate is a good option, particularly if it is a sympathetically mediated or if there is a sympathetic element to the pain. Then it does help the stellate ganglion injections. We don't normally. I mean, it's fascinating the way you thought about it, because it's not something which comes to our mind directly. But it's not that we haven't done it, but it's not something we do it on a regular basis. But yes, in head and facial pains, when there is a sympathetic component to it.
Thank you. Can I? And there's one more thing. One more question. Can I ask?
Yeah, please go.
We get a lot of trigeminal neuralgia patients with more of a V2, V3 involvement rather than V1. In such cases, we have tried selective mandibular and maxillary ablations via the coronoid approach. So, do you have any experience with that? rather than go for the Gasserian directly?
See, it is isolated nerve blocks, the maxillary nerve blocks, and the mandibular nerve blocks. But the one and block a Glycerin injection or a Glycerin ablation. The one challenge we have is we do not know how long. If you do a Glycerin ablation, if you catch the trigeminal nerve roots, which is at V2 and V3, then we know if there is hypoesthesia, then there is a guarantee that it will work at least for 2 to 3 years. With a bit of luck, maybe 5 to 7 years. Whereas in peripheral nerve, we do not have that sort of choice. And if you're going to do a conventional radiofrequency ablation of the peripheral nerve, you also increase your risk of anesthesia dolorosa. Because you get a numb area with a lot of pain. Because ablating it close to the ganglion and ablating a peripheral nerve are two different things. Whereas ganglion is safer, though it is safer in terms of complications like anesthesia dolorosa. It's not necessarily safer in terms of procedure itself. In fact, it's much more complicated. But you reduce the risk of anesthesia dolorosa, and there is not a big sort of a body of evidence to back the peripheral nerve injections, if you want to compare it with the Glycerin ablation. But having said that, a lot of people they don't even do the maxillary and mandible. They kind of, if it is V2, they just do the infraorbital nerve block and do an infraorbital ablation. And I do have a big set of patients, at least 25 of them, who have undergone, the surgeons previously used to do a neurectomy. They used to go and cut the infraorbital nerve. For the V1 trigeminal, they used to go and cut the supratrochlear and the supraorbital nerve. They come back after 6 months, 1 year, saying that their pains return. So in those cases, we go back and do the trigeminal ablations. I'm not saying it shouldn't be done, but I'm saying that there are positives and negatives on both sides. So you can definitely do the maxillary mandibular peripheral nerve blocks, but it is not superior to trigeminal to the Glycerin ablations. In fact,
So, Dr. Vijay, that means in a patient with a pain that is governed by these nerves, who have, a shorter life, we're not really worried about 2 to 3 years of it working. It could be considered, right? Hello, am I audible?
Yes, Dr. Vijay.
Yes. The connection just went off. Actually, I think Dr. Nandini was just starting the question, and then my connection went off. Can you repeat that question, please?
Dr. Vijay, I was just following up with Dr. Sushma's question about the using these peripheral techniques when we are not really too worried about long term, because we just want to give adequate pain relief for the remaining quality, for just the sake of quality of life, and it's a much shorter term that we are looking at. And if it is feasible to approach that nerve, if that area is diseased, is such that we can reach it, it could be considered, right, in a palliative care setting, because we are not looking at many years of impact.
Sorry, I think I missed the crucial part of your question again. I think see, if the lifespan is short, and yes, if it is a short lifespan, instead of proposing these expensive ablations and whatnot, go and put in some phenol or alcohol, which is going to do a neurolysis, and that can give a long-term benefit. It works for 3 to 6 months, these phenol injections. So that is possible, and it is sometimes that's the only option we
have. Can you just, since it's the last lecture, if you could, summarize what are the most important points for selecting intervention as an option, like so that if people go back from this echo understanding very clearly the basics of using this particular technique that is available to us. Dr. Vijay, could you please summarize the selection points of both patients as well as the the specialists and post-op, post-procedure requirements.
I mean, the different cancers, particularly from a palliative care perspective, I could think of different cancers and when you can actually do the procedure and how much it might benefit. There are certain procedures, I mean, as we were explaining earlier, which kind of has the benefit of getting it done earlier. Particularly the celiac neurolysis, which seems to be the commonest procedure which is done in palliative care, and it is also the procedure which has got a good body of evidence, and it is something which we have to do earlier, because if someone has ascites, then it becomes a problem and you can't sort of turn them prone for fluoroscopy. Not everyone can do it. I think Dr. Sushma Bhatnagar might have spoken about the celiac neurolysis. She does a lot of them under ultrasound, which is a much more comfortable and easier way of doing, particularly when the patient has ascites. But still, it's better to get it done earlier, before the nerves get infiltrated by the tumor, and it becomes less effective. Now, the head and neck, again, it's a balance. What we're talking about today, we have had patients who were reasonably comfortable on opioids, anti-inflammatory, neuropathic pain medication to an extent, and then suddenly they start developing these pains, which we know that if we could have intervened earlier and done the ablation, they would have got better benefit. But now we are not able to do the procedure because, say for instance, typically there is a tumor invasion of the foramen ovale, and the pain is over the V2, V3 distribution. You know that ablating the trigeminal earlier would have given them a better benefit. Because now you think twice, particularly if it's a vascular sort of structure sitting in the foramen ovale, and you stick a needle into it and it starts bleeding, and you're in trouble. And so it's a fine balance, actually. I don't think there is any sort of right or wrong answers with it. But I mean, me being a little bit trigger happy with the interventions, if you ask me, I think I will try the conservative measures as much as we can. And if I see that there is a dose escalation, or if I see that the patient is not entirely comfortable with the management, and if I think that there is a procedure which chance of benefiting the patient, then I would propose those treatments to them.
Thank you. And I guess we should, it will be very important to communicate with the intervention pain specialist as to what are the objectives of reference, because, and they should know a bit about the background about the patient. So just writing a referral note to the patient may be doing a lot of disservice. So unless there is clear communication about the background and the objectives, and the intervention specialist may know that this particular technique may not work in that patient, or maybe another one will work. So it's very important to write the main priority of the patient, because we should not end up losing an important function because we... Hello, am I audible?
Yes, you are audible, yes.
Yeah, so I just wanted to, just remind our palliative care specialists about the importance of communication with the interventional pain specialist, because the objectives have to be made clear. That's all. And before that, we would have to have a detailed communication with the patient regarding, what are his priorities, and, and even after they consult the interventional person, before the procedure is done, I think it will be important for them to clearly articulate all that they understood, including possible complications, and they are, making an empowered, autonomous choice.
Okay.
I fully agree with Andini, because I mean, unless that conversation takes place, the thing is, just referring the patient it doesn't help, because it's like the interventional pain specialist. Just imagine, he's like a person with a hammer. So for a person with a hammer, everything looks like a nail. So, I mean, whenever there is a chance to stick a needle and do something, then they end up doing that. So you got to be very careful in conveying what you would like to by referring this patient. And sometimes better to evolve a consensus, which procedure might benefit, and then give it a go rather than just referring the patient to the interventionalist, because the only procedure he might know is a C neurolysis. So whichever cancer you might refer, he might end up doing is neurolysis. So it's very, very important to communicate what is actually.
Okay, thank you. I think Dr. Mary has a question.
Yeah. What I wanted to tell was, I mean, you're saying about ultrasound guided nerve blocks of the face, right? Supraorbital, great occipitally. But I've been doing a lot without ultrasound, because regularly in neuro anesthesia also I used to give the complete scalp block and all. So, I mean, as long as you're careful, I mean, is it okay not to use ultrasound? Because everything you can do, your auriculotemporal, supraorbital, supratrochlear, greater occipital, greater, less occipital, I've been regularly doing it without ultrasound. So in those people who don't have an ultrasound machine, I think this is a fairly good option with not too many complications if you take the regular precautions. Is that okay, Vijay, or are you insisting on ultrasound for this?
Yes. I'm not insisting, because I think it's a very easy thing. I mean, the easiest injection you could do is the orbital injection, and there is no. I mean, the reason we've been talking about ultrasound is if we do an injection and if they do get a good response, and then we would like to follow it up with some sort of an ablative procedure, then ultrasound becomes important. If it is just for a quick pain relief, which might last for a few hours to up to a few weeks, I think because it's just the volume. You put in 1 ml just above the eyebrow, it covers the supratrochlear, supraorbital completely, and you just put an ml just in front of the tragus, and you tend to block the auriculotemporal nerve. So, as Madam was mentioning, it's an easy thing to do, and you don't necessarily need an ultrasound to do the blocks. But if you want to be specific, say, if in instance, if you want to put in some phenol, 1 ml of phenols, and we would like to be as close to the nerve as possible. For instance, if you want to do a pulse radio frequency, where you have to be exactly perpendicular to the nerve, that's when the accuracy becomes important. That's where the ultrasound gets important. But if for a palliative care perspective, where you want quick, efficient, safe, effective pain relief, I think you can do.
Because that will be a very valuable skill that they can use, at least in their consulting team. Please consider having a small workshop.
I can always come to Trivandrum sometime, no problem. Thank you so much.
We are coming to the end of interventional pain management session. So in the first session, we had a multiple choice questions that all of us have done. So I am launching it again. So I request all of you to please do the multiple choice question, and we will do it now. So I'm launching it from here.
Sunil, would you like to ask how many of them gave the pre-test? Like, we don't know that the same batch is continuing. No? Just to know how many of them were there from the first batch.
So, yeah. How many of you were there in the first session?
You could answer in the chat.
I think there are 2 or 3. I think 2, 3, 4. Yeah.
We need to find a way of, carrying on the same type of same batch, because when the pre-test and post-test make 10. Anyway, let us just check our knowledge levels. That's all.
Yeah. So I hope all of you can see the multiple choice question. So you can select the right answer, and after filling up, you can launch, click the launch polling. Sorry, we are launching the, yeah. Only four of you have finished. Anybody else is going? Yeah, five has finished.
Sunil, why TIPS is not taking part in the survey?
Tips already took part.
But this is post-test.
Yeah, we did.
Then how come only 5 entries?
I don't know, but we already did. We submitted.
You mean collectively?
Yeah, yeah.
That's not allowed.
It's a team effort. Team is important in palliative care. I think nobody else is doing now. Shall we stop?
Ask if, is there anyone else pending? Can raise your hand.
Anybody else is doing now? No, I don't think. We will stop. So, shall we move on to case presentation?
You have to show the results, no?
Yeah. So, I think, yeah. Dr. Vijay?
I think it's the first one is post-ganglionic, isn't it? It's not pre-ganglionic. I think
Okay.
C is the right one. The lumbar sympathetic chain, yeah, I think most people got it 100%. Number 3, lumbar sympathetic block except CA pancreas, I think 60% got it right. Not a sympathetic ganglion, dorsal root ganglion, again 80% got it right. The 5th, number 5, stellate ganglion block, all of the above. All of them got it right. Possible complication, all of the above, all of them got it right. Number 7, also retroperitoneal structure, everyone got it right. Anatomical landmark, all of the above, again, everyone got it right. Which of the following is true for lumbar sympathetic block? Is more effective. Now the thing is, it's not very helpful when the anti-brachial pressure index is less than 0.3 actually, so it's a bit of a trick there. It is not helpful in big ulcers, and it is independent. And now the improved blood flow is with sympathetic block is due to is AV shunting. Actually, the question is wrong. Actually, it is not due to. I think all three A, B, C, all three answers are right. I think it's my mistake framing the question, which means not due to, the answer would be B. If it is due to, the answer is the first 3, which I think a lot of people got it.
Okay, so we will move on to case presentation. We don't have much time.
Dr. Vijay is staying on for the case presentation. Would you have time, Dr. Vijay?
Sorry, yeah, I'll have to leave the case presentation. So I would suggest you to carry on, and thank you very much for putting up with me for the past 2 months. And it's been a good experience. So thanks a lot. Thanks for listening.
So, Dr. Vijay, it has been an enormous learning experience for us. Thank you so much for meticulously preparing your slides with very, very practical visuals. And we can see the effort you have taken for, making this meaningful to palliative care physicians. Thank you so much for being part of this whole venture. And the intervention pain management, we have got some idea now. Thank you very much. Sunil, would you want to say something?
Thanks a lot. Thank you.
Dr. Vijay, thank you because you were our faculty for the last 2 months, and it has been wonderful to have you with us. Thank you so much.
Yeah. Thanks, Dr. Sunil. Thank you, and you've been persistent. You never left me alone. Thank you.
And one thing important in ECO is that if you successfully do all this, we are going to trouble you again. So please don't feel that you're free now. We are going to trouble you sometime in the future.
So the presentation is going to be done by Dr. Saurav. Saurav?
Good evening, everyone. Am I audible?
Yes, you are audible.
Good evening, everyone. Today, actually, I'll be presenting this case, which we have encountered over the past about 5 or 6 months. Now, yeah, so this is a 70-year-old lady from Siliguri, which is in the northern part of West Bengal. With no comorbidity, she complains of an ulcer, with main complaint of an ulcer in her tongue of 4 months duration. And with this complaint, she presented here. On examination, there was a 3 into 3 centimeter ulcerar proliferative growth in the left lateral border of the tongue, which was not crossing the midline and not till the base of the tongue. There were no palpable lymph nodes. A biopsy was done initially, which was squamous cell carcinoma. And after evaluation, she was taken up for surgery. And the surgery was done in April 2017 with a hemiglossectomy, a left-sided neck dissection, and a right supraomohyoid neck dissection. The pathology details showed a well-differentiated squamous cell carcinoma. The stage was T3N1M0. It was a fairly large tumor with one node positive in the left side of the neck. Post-surgery, she was then taken up for adjuvant radiotherapy, and radiotherapy was given at our center with a standard fractionation dose of 60 grain 30 fraction, and the entire procedure got over in the month of July. When she came after 1 month in the month of August for follow-up, clinical examination showed that she was absolutely fine. There was no recurrence. The second follow-up after 3 months also was absolutely normal. But in December 17, that is since last month, she presented suddenly with complaint of severe throat pain and dysphagia, and a swelling had come out in the right submandibular region, which was for 1 week. When we saw it was about a 3 to 3 centimeter node, we got an MRI done, which confirmed the findings, and FNAC was done, which showed recurrence of squamous cell carcinoma. We got a PET CT done to see where all the disease has spread, and it showed that it was all over in both the neck. I'm so sorry, the light has gone here. Yeah, so it showed that there were nodes in both the neck and a large submandibular node. So the tumor board, all the patients go through tumor board in our hospital, and the surgeon saw, and he said this was an inoperable disease. So the next question was obviously what to proceed with. One option was palliative chemotherapy. The other option was best supportive care. Now, she is 72 years of age. Palliative chemotherapy would have been difficult. She was not in the best of condition. So after discussion with the family members, in view of the advanced stage and the side effects of palliative chemotherapy, we thought of best supportive care. And because by that time she was very weak, not able to come to the hospital regularly, we said that we will start visiting her at her home. And we started with the palliative team home visit and made the first visit about 10 days back. When we saw her, she was bedbound. In 20 days, her condition had deteriorated drastically. She was extremely weak, severe pain in the throat and the mouth, and there was radiating pain, excruciating radiating pain to both the ears, and she was coughing, especially on having liquids. We confirmed it by giving some water in front of us, and she just coughed it out. Her performance status was very bad. She was bedbound, as I had said. Her pain was about 8 out of 10. She could not sleep because of the severe pain. There was total ankyloglossia, and the chest on examination showed bilateral basal crepitations. The family members, they knew what is the condition. They were very caring towards her, both the son and the daughter-in-laws. The main concern which they showed when we talked to them was that we just cannot see her lying like this. I mean, she's not able to eat anything. We want something to be done so that at least something goes into her. And they were also concerned that she could not sleep even for a couple of hours, for even 1 or 2 hours because of the severe pain. Initially, she was on paracetamol 500 mg 6 hourly when we visited. So then we talked with the family members, and so we in view of the severity of pain, we started her on morphine with 5 milligram 6 times in a day and 5 mg SOS. We continued with the paracetamol. We gave her we gave her antiemetics and Dalcolax to take care of the constipation, pantoprazole, and Ryle's tube insertion was done in view of the family member's request, and since she was aspirating. we also said that to let us know over the phone after a couple of days of how she is doing. And after exactly 2 or 3 days, they called us up and told that her pain is actually less. We plan to again visit her after 2 weeks. So this is the presentation in short.
Thank you, Dr. Saurav. What is the key point that you would like to discuss in today's meeting?
So there are three things which I have encountered after this visit. Number one is that which of real concern is, since I'm working in a cancer hospital, which we have started with the palliative care recently, but we cannot make visits regularly. Now, exactly about 2 days back, they said that her condition is better, but when are you coming again? So the expectation of the family members, how to meet that, number one. Secondly, regarding the pain management, we had this fantastic presentation today on the interventional pain management. I'm not talking about this case in particular, but in such patients where we know that pain is the main issue, when should we actually intervene? I mean, she is now on morphine 5 mg 6 times in a day. We suppose increase it if we see that the pain control is not satisfactory to 10 milligrams. But even after that, we see that it is still not controlled. Should we then think of our intervention pain management? Because morphine, as we know, has no ceiling dose. So, I mean, should we keep on increasing it, or should we ask for a specialist opinion? That is number two. And number three is how right I am in putting the rice tube for this patient. So these are the three main questions that I really need to ask.
I think we'll let the group here respond first, Sunil. And before we open, and I just have a request to all the participants. I don't know, maybe you have already used a camouflage name, but whichever patient that we are discussing, don't name the patient. And if we are showing the pictures, mask the face with some black square or rectangle or something, so that the anonymity is maintained.
I'm so sorry.
Just as a precaution.
I'll keep this.
It's a good habit, not only for
yes,
this.
Yes, definitely.
It's a good habit for all of us to have.
Absolutely.
Yeah. So now we open those three questions of Dr. Saurav to this group, because we have finished so many classes on such discussions. So it would be very nice to hear how you think. Was it ethically, was it the right thing to do, the rice tube? Secondly, should interventions be considered? And thirdly, about the dilemma regarding home visits and expectations management. I think we'll begin with the home visit part and then move on to the other two. Is that okay, Dr. Saurav?
Yes, madam, definitely. Yeah.
So, Dr. Mary?
I saw that you're unmuting me all the time and I'm muting myself.
No, the problem is, I think.
No, Sunil, wait. Mary always involves in discussions. I think you should request the part.
Yes.
See, I cannot switch on my video because of an internet problem. But please, all the participants, this is a very virtual discussion, and it becomes even more remote when everybody switches off video. Please come online. And I think Mary definitely comes out with her questions spontaneously. So if you participate, there's no problem. All of us are friends here. And unless we discuss our thoughts out, how are we going to, exchange learning? Maybe you have an answer to some things which Dr. Saurav is looking for.
The problem is that only 3 or 4 of us are here, and one is me, Dr. Mary, you, Saurav, and Dr. Iqbal.
I see.
So that's why I asked. Otherwise, we have to discuss that. That's the problem. It's already 5.
I see. Okay then.
So
then maybe we can carry on this discussion next time. Will that be better? because it's not going to finish in 5-10 minutes also, no? So if it's exceeding the time, I mean, do you think it's a better idea to, because this is a very good case, and I think we can have a detailed discussion without any, having more participants. I think that would be more useful. I think that's my opinion. I don't know.
Mary is very right, but Saurav may be having some burning question in this particular patient. Then we could quickly, respond to him, and definitely we need to also have some kind of a discipline whereby before, writing off, someone could say, that we are unable to continue for the case discussion. It cannot be as sudden as that. Or is it that 5 o'clock only at everyone disappeared at 5 only?
Yeah. So Saurav, we think we will discuss it on another day. Do you have any questions that need to be asked right now?
No, it's absolutely fine, sir. It's absolutely fine. I think we can have the discussion on some other day if everyone is willing, so that I think I can have some more inputs. So if that is fine with everyone, I don't have a problem, sir.
Okay.
So Sunil, when is the next? Now, actually, from my understanding, all our sessions are done, right? This particular pattern that we followed, this was the last one, right?
So this was the last one on interventional pain management. Now we have a difficult pain after 2 weeks.
Okay, fine. So then we will keep. Is it okay, Dr. Saurav, when is the next date? Sunil, ask him, because this would be something that he's requiring, or that we can have different conversation with Dr. Saurav just on some specific questions. This is a very, very interesting case for everyone to be present. All 3 questions are very relevant, but it all will lead to detailed discussion. That is what Dr. Mary brought up, and I fully agree with her.
I think it's on February 2nd.
Dr. Saurav, February 2nd is okay, or is it too late?
No, it's absolutely fine. I just think I might be traveling that day, but if I'm not, then I'll be there, because I think that's a Friday again, and generally on Fridays I go back home to Calcutta. So I think Friday 2nd I'll be flying, but I might be here as well. So if I'm there, I'll definitely be online, madam.
Saurav, even if you're in Calcutta, you can join in, because today I'm not in Delhi, I'm in Bombay, but I've joined in, So wherever you have, thanks to internet, you can join in.
No, and I have connected through my mobile, actually.
Yeah. So if I fear my flight is at about 3 o'clock in the afternoon. So, but I need to check. If I am there, I'll definitely join.
Okay. So, shall we stop now?
Okay, yeah. Great. Today was a good discussion.
Okay. Okay. Saurav, by the way, Dr. Saurav is an oncologist, radiation oncologist, who has done 6 weeks certificate course from TIPS recently. And he is very active. He has started home care, and he is doing many things after getting training in palliative care, including subcutaneous, subcutaneous, all the things that he has done.
It has really helped over the last. After coming back, it has really helped me, sir. Thank you so much to all of you.
Okay.
Wonderful, Dr. Yeah, so okay, then we'll meet up during the next eco session. And if there's anything that you need to clarify, the TIPS team is available, Dr. Saurav. That can be a separate conversation, but I think this case should come for discussion for everyone to benefit.
Okay. Thank you. Bye-bye.
Bye. Thanks.